Hello, everybody, and welcome to Modern Sex Therapy Institute's Sex Summit. Don't get left behind, become a modern, sexually competent therapist. My name is Dr. Rachel Needle. I'm a licensed psychologist and certified sex therapist, and I am co-director of Modern Sex Therapy Institutes. So, Modern Sex Therapy Institutes is a continuing education provider. We offer both individual workshops online, live via webinar, and in person in 8 different states, as well as a number of certification programs, including sex therapy, couples and sex therapy, LGBTQIA affirmative therapy, alternative relationships, transgender mental health care, medical sexology, sex education, and sex counselor certifications. So please go to our website, www.modernsextherapyinstitutes.com, to check out all of our great offerings. Again, both online workshops that are delivered via our state-of-the-art learning management platform that we use, and everything that's upcoming both in person or live via webinar as well. We also offer a PhD in clinical sexology, and the application is also on our website. It's a 2-year program for those that have no training. Some credits might transfer, so go ahead and check that out, and if you have any questions, let me know. Again, thank you for being here and seeing the value in this incredibly important topic. You don't want clients to come in knowing more than you. You don't want to use the wrong terminology, which could turn your client off or even offend them. So it's important to be sexually informed, sexually knowledgeable, sexually competent, and you are taking the first step to getting there. So thank you for being here. And if you have any questions, you can reach me at Rachel@modernsextherapyinstitutes.com. Enjoy the summit. This just in, if you have not taken your sexual attitude reassessment, otherwise known as the SAR, it is now being offered for the first time ever online. Our next one is May 13th to 14th, being facilitated by Shadeen Francis and called Sex, Kink, and Social Identity. It's going to be fantastic, and we hope to see you there. You can learn more on our website. Thanks so much. Hello, everybody. So, today I want to talk to you about what is great sex. But first, I want to go into talking to your clients about sex because that's something that not a lot of us have experience doing or have historically been comfortable doing. So, again, as our goal is to help make you a more modern, sexually competent therapist, I want to go into a couple details to help do that. So, when is it important to talk about sexuality? And my answer is always. So sexuality should be discussed with every client. The same way that you gather history on other areas of their life, which I know you do, you should be doing that about sexuality as well. So during an initial assessment with an individual, with couples, with parents, when working with adolescents, when working with the mentally ill, when working with the terminally ill, timing is everything, of course, but it should be discussed with every client, or at least asked about, so that you open the door. A lot of people don't open the door to talking about sex and sexuality because they feel like, A, they're uncomfortable with it, B, it's not my role to, which I disagree with you and happy to have a conversation about, or C, I'm going to open this door, they're going to say something, and then I'm not going to know what to do with it. So that means you're, not being educated and not knowing. But as long as you open the door and give them the permission to begin talking about sex and sexuality, you can then decide, if you are not the appropriate person, who to refer to, and let them know that it's okay that they talked about that, this is really positive that they did, and help them get to the right person if you are in fact not that person. So over half of therapists don't ask about sexual issues. Now, to me, that's a huge concern. Again, everybody who walks in your office is going to be a sexual being in some way, right? Because when we talk about human sexuality, we're not just talking about sex. We're not just talking about the behavior and the actions, right? And functioning. We're talking about gender, sexual orientation, anatomy and physiology. We're talking about, things like menstruation and puberty. So human sexuality and sex in general encompasses a whole lot of different things, not just actions and behaviors and functioning. So it's really important that you do talk about it. So congratulations, because those of you who are not comfortable already talking about sex and sexuality, you are taking the first step towards being a sexual resource for yourself, your agency, your practice, and your clients. So you don't have to be sex therapists to be helpful and to be able to be competent, sexually competent. I think it's important that therapists look at, especially when it comes to sexuality, their own attitudes. So take a couple seconds and even write this down and think later and think about what your limitations are, what your biases are, what your boundaries are when working with clients in general and when it comes to sexuality. Sexuality is complex and encompasses many components of life: physical, emotional, and spiritual health. Sexual awareness can contribute to better comfort engaging with clients with a wide variety of sexual attitudes, behaviors, and values. So I want to make sure that you are comfortable talking about sexuality. And if you're not, to just know what your limits are and maybe even think about that as something that you can start to work on and work towards becoming more comfortable. Sex is good for you. So the act of sex improves health and happiness. So we know that overall research has shown that those that are sexually satisfied also express higher satisfaction with quality of life and their relationship. So if you're sexually satisfied in your relationship, you're more likely to say that you are more satisfied in your relationship. So sex has a lot of health benefits. It boosts our immunity. It can help decrease stress levels. Orgasms can lead to pain reduction, including and help cure headaches. It burns calories, so it's cardiovascular exercise and can contribute to your cardiovascular health. And I could go on and on, but the point is that it is really good for us. And orgasm is specifically, and sex in general. When we look at sex, there's a lot of things that contribute to our sexual function. And this is really important to know when working with clients, to be able to be a detective and try to figure out all of the things that have led to what they're experiencing at this time. And one of the reasons that's important is that a lot of times therapists will try to make will assume a linear causation. So for example, and I'll use the sex example, of course, someone comes in and says that they have sexual pain or pain with intercourse. And then you learn during your eval or talking to them that they had experienced a rape at one point in their life. All of a sudden, it makes sense, right? You have this aha moment. It must be that because they are raped, that is why they are experiencing sexual pain. So it may or may not be part of the picture. So there's always a number of contributing factors to sexual function. And rarely is it just one thing. And when I look at a client, I try to imagine the client. It's like I have a poster board. The client is written probably as a stick figure because I can't draw in the middle. And all of these arrows kind of pointing to the client, all the things that could have contributed to where they are today. And specifically, we're talking about sex, so sexually where they are today. And oftentimes I add to that throughout the therapy process. But in the meantime, I look at all of the factors that could contribute. So let me just give you an idea of some factors that could contribute to sexual function or dysfunction. So we have biological and hormonal factors. So those are your androgens, your estrogens, your medication, illness, fatigue. Expectation of outcomes. So past history of good or not so good or disappointing sex can contribute to your sexual function. Contextual factors could be privacy or lack of privacy, safety, and emotional rapport. Intrapersonal or development history could include things like trauma, like the rape that I just gave an example of, negative emotions such as anxiety, fear, shame, or guilt. And when we look at the healthy sexual functioning, it could be positive experiences with sex and positive emotions like joy and happiness and connection that contribute to our good sexual functioning. Interpersonal issues, so great relationship or relationship discord. Of course, relationship discord could contribute to dysfunction. Absence of emotional intimacy or presence for healthy sexual functioning. We have lack of appropriate stimuli, or good stimuli. So if your partner really knows or partners know how to please you and are good lovers in a lot of different ways, that could contribute to healthy sexual functioning in a relationship. However, if there's partner dysfunction, so in other words, if clients coming in saying they're having difficulty orgasming, and let's talk in a heterosexual couple in this example, they're having difficulty having an orgasm during intercourse, and then you find out, you ask about their partner's functioning, and you realize that the partner has ED or is or erectile dysfunction, then it would make a little bit more sense, right? That could contribute. So the reason that somebody might not be able to orgasm might be because they're not being properly stimulated, which could also be a result of their partner's dysfunction. So I look at the biopsychosocial model of sexual response, where we have the biology, the psychology, the sociocultural, and the interpersonal factors all contributing to a person's sexual function. So the question, what is great sex? Consent, communication, enthusiasm, connection, compatibility, mindfulness, pleasure. So for great sex, people have to be comfortable and feel good about themselves. So there's a lot of things that contribute to great sex. And first we have to start with, what does great sex mean to the person that we're talking about? And so communication is hugely important in that way as well. Because what would be great sex for me, and what would I would need to say, oh, I had great sex, might not be the same as for somebody else. So first we need to understand what that means. We have to feel good about ourselves to have great sex, right? Because we have to be able to feel confident and comfortable in our own bodies. So doing things that make you feel good, whether it's, eating healthy, doing something that else that made you feel good, that then makes you feel sexy, buying a outfit that you enjoy or feel good in, exercising, and even boosting our partner's confidence will help with our own confidence. So there has been a study, it was in the Journal of Sex Research, that reported to be higher among the couples who revealed that they gave each other, that said sexual satisfaction was higher among the couples who revealed that they gave each other positive affirmation during sex. So that could lead to great sex, is being able to feel good with your partner and exchange positive affirmations during sex. Masturbation, so for those of us that feel comfortable, getting to know your own body and knowing what does it for you, what doesn't, what feels good, what doesn't, will contribute to you being able to have great sex with a partner. Because then you could communicate with the partner what you like and don't like, because you will know. And even studies show that masturbation, a lot of people will say, well, if I masturbate, I won't want to have as much sex. Or they assume that if their partners are masturbating, that's why they don't want to have sex. But studies show that masturbation doesn't make you want sex less. It actually has the opposite effect. When you masturbate and you get excited and aroused, you likely will want it more. So I talk a lot about outer course. So some people refer to it as foreplay. I don't like that word because it insinuates it's leading to something when it doesn't have to, because penetration doesn't have to be part of great sex. So outer course, don't just focus on penetration. Focus on touching each other and all the sensations that are part of feeling good when we're being sexual with somebody else and being touched, and all of the excitement leading up to sex. And that can even be kind notes and gestures. It doesn't even have to include sensual or sexual touch. So for great sex, we have to just, listen, no one's saying that a good quickie can't be great sometimes. But when we talk about great sex on the whole, we want to say we can have a variety, not just quickies. We want to be able to, enjoy sexual activity for a period of time where we're connecting again with our partner, where it's not rushed, and where we're able to communicate, where we're able to experience sensual sensations and feel everything that's happening at that time. So enjoy outer course, enjoy novelty. So try new things. Trying new things can be really exciting and lead to an increase in dopamine, which is, what we're really sometimes looking for. That's what we have at the beginning of a relationship. So we want more of that. So novelty doesn't have to be hanging from a chandelier, although, if you're safe, there's not anything wrong with it if you like it. It can be safe, but it can be sex at different times, sex in different rooms, different positions. So my disclaimer on the chandelier, of course, is make sure it's mounted properly and then have fun, but, it doesn't necessarily have to be that. Sex doesn't actually even need to be spontaneous. So spontaneous sex can be great, but so can leading up to a planned sexual activity. You can still do things to get excited and lead up to it, and for novelty, and you can be spontaneous without being spontaneous. And what do I mean by that? So your partner doesn't have to know everything that you're planning. So let's say to your partner, it might seem spontaneous, but you've decided that tomorrow you're going to get up 15 minutes before you need to really get up, and you're going to, perform oral sex on your partner or do something and start touching something that's sexual with your partner. So it may be spontaneous to your partner or your partners, but it's not to you. So that can be really exciting too, and that's something novel. Communication is one of the most important things in great sex. So being able to be clear with your partner or your partners about what you like and what you want. So communicate. Research suggests that better communication is key to better sex. So don't forget about that. And lastly, practice mindfulness. Or not lastly, actually, I have one more. Practice mindfulness. So it's a great tool. Mindfulness is about cultivating that present moment awareness whereby every sensation is observed and noticed, and we keep coming back to that. And that is directly from Lori Brado. That's how she talks about mindfulness. And she has a great book on mindfulness and sex. So definitely check that out. She also is going to be a speaker for a webinar in May for us. If you're interested, check it out. But basically, we want to make sure we're staying in the present moment and enjoying sexual activity and every sensation leading up to feeling aroused and excited, and enjoying it in a non-judgmental way. So when we're having what we call busy mind, right? When we're not mindful and our mind's all over the place thinking about, did I do this? What do I have to do next? And, something that a lot of us have gotten accustomed to on a regular basis. When it comes to sex, that's no different, right? That's how our mind goes. But when we do that, we really take away from our experience and of being sexual and feeling those sensations and getting aroused and having really great and enjoyable sex, whether with ourselves or with someone else. So you want to make sure that you're practicing mindfulness and experiment with new things. So toys, props, anything at all that's different. Again, this goes back to the novelty, but this has to do with introducing new things into your sexual repertoire and try that out. And if you like them, then great. And you can do it again. And if you don't like them, then you stop. And that goes back to consent. You can stop at any point with yourself or with somebody else. So those are some of the keys to great sex. Again, my name is Dr. Rachel Needle, co-director of Modern Sex Therapy Institutes, www.modernsextherapyinstitutes.com. Please check out our website, all of our wonderful upcoming workshops and webinars, and thank you so much for your time.
To be here with the Modern Sex Therapy Institutes, the 2020 Sex Summit. What is consensual non-monogamy, and how do you support clients in negotiating it? Let's get started. So, what is consensual non-monogamy? It's also known as responsible partner sharing. It's an umbrella term used to describe when partners have decided together to allow and to be honest about having more than one sexual relationship at the same time. Consensus and honesty are hallmarks of consensual non-monogamy. It's also known as ethical non-monogamy. There are two types of consensual non-monogamy that we see. One is polyamory and one is expanded monogamy. Polyamory refers to loving more than one person simultaneously, including sexually insignificant ongoing relationships. Single individuals who espouse the values of polyamory may be considered polyamorous. We call them solo poly. Expanded monogamy is a term used to describe married or committed couples who expand their sex lives. These may include swingers who don't look for love relationships, couples who share sexual encounters with friends, and couples who allow extramarital affairs but do not share partners. The formats include open relationships and swinging. So the two types of relationships in expanded monogamy, one is swinging, one is open relationships. Swinging is often with short-term or anonymous partners. Love relationships are neither sought or intended. Couples may consider themselves monogamous because they share sex outside together. So for an example, this would be a couple that's getting to have sexual activity with another couple. Open relationship is a relationship that is open to additional partners who may not identify with polyamory or swinging, Both partners may not choose to seek ongoing additional relationships. Either may or may not know their partner's other partners. Single individuals who espouse open sexual values may belong to this group as well. So, in other words, it can be sexual, but it can also have some relationship component to it. So, ethical non-monogamy or consensual non-monogamy, it's an umbrella term, right? So just for a quick breakdown of the three subsets of consensual non-monogamy: polyamory, again, more romantic, long-term in nature; swinging, sexual in nature with couples usually together; and open relationships, primarily sexual in nature, but can also be romantic. So stranger sex, random hookups, swinging, friends with benefits, relationship anarchy, meaning that there's really no rule involved, and then polyamory. So why do people practice consensual non-monogamy, and why maybe they will go to your office for help? Increased happiness and health among adults. We also find that there's increased passion and sexual variety in relationships, so there's diversity with the sex that they want. Shared partnering, shared parenting and familiar responsibilities. We see this more with polyamory. Personal and spiritual growth, expanded intimacy and bonding in adult relationships, and it gives a freedom of sexual expression. Consensual monogamy, it takes work. Regardless of how consensual non-monogamy is defined or by whom, every type of consensual non-monogamy must adhere to these rules to be successful. It requires honesty. It exists on a continuum. It's hard work. It has reported benefits, and it exists in various formats, which I'm going to talk to you about. So it requires honesty. Consensual non-monogamy requires all partners know that other partners are involved. Each individual makes an informed decision to be intimate, even if indirectly, with more than one another. The consensus creates the necessary context for every partner to incorporate health, safety, and emotional responsibility with each other partners. How and what is revealed by partners may not be perfect, but consensual non-monogamy is being practiced only when every person is aware all of the others are involved. It exists on a continuum, so labels and what they mean are not important to some, but are important to others. Marginalized individuals are helped by finding out they belong with others who are similar and sympathetic. So they're going to go to other partners that have other things that they have in common with them. While there is some agreement as to the meanings commonly used consensual non-monogamy, terms individuals and couples, triads, quads, or pods may have developed definitions on their own, and it's important to know that when they come in for help. Therapists need to understand what labels mean to those who use them. So what are they? Do they have play partners? What are all of those terms that they may bring to the office? If partners do not use terms, it may be helpful to define and create some with them. To learn about and identify with a particular label may clarify a place along the continuum of belonging. In therapy, it is important to have each person describe what is meant by the terms used. It builds a framework for illuminating each person's expectations and their role and perhaps in their group. Whether or not labels are used by consensual non-monogamy clients, the therapist needs to discover each person's expectations of what they want and who they are, their visions in the relationship, and their ideas of what goes on with their other partners. The continuum of consensual non-monogamy is on one end close to tradition, and on the other are radical new models, and variations exist between them. The major difference between one end of the consensual non-monogamy continuum and the other are attitudes, behaviors, and levels of involvement. Partners who view themselves as being traditional relationships live as committed couples, but have some form of open or expanded sexual agreement. Such partners may or may seek ongoing, meaningful additional partners. Shared information and experiences vary in amount and depth. The most traditional are don't ask, don't tell couples, and I see this all the time in my practice. They have negotiated an open agreement, but neither one knows the other's outside partners, and the couple does not share information or logistics of their extramarital relationships. So in other words, this couple made an agreement, but they rarely, if ever, talk about it, and they share nothing of each other's outside activities. They are, however, honest about their marriage with outside partners. On the other end of the continuum are those who are living radically new lifestyles. This includes those who find themselves or seek and want meaningful, ongoing love relationships with all partners, whether or not partners live together, and regardless of how much time is shared. Representing the most inclusive polyamory might be a polyfamily with 3 or more adult partners, all of whom live together and share intimacy as well as finances, parenting, and household management. So, on one end, you really see this more traditional couples. They have boundaries, they may have hierarchy where they're primary partners, but they don't share anything else. But on the other end, you see this other more kind of liberal, laid back type of approach to it where everyone's involved and there's more committed relationships and couples are talking about it with each other. In between these extremes are open couples who do share knowledge of extra partners, those in meaningful relationships with extramarital partners who do then, swingers who are married or committed and share their sexual liaisons with partners, and couples who share sex with friends they care about but not live in relationships. All relationship types of consensual monogamy include consent and honesty, but why and how relationships are carried out takes many forms. Consensual non-monogamy is hard work. Those who practice consensual non-monogamy say it can be fun, but overall, a lot of work is involved in carrying out responsibility more than one intimate relationship at a time. Poly people and others in expanded monogamy are individual humans, no more automatically gifted in successful relationships than anything else. Those in consensual non-monogamy find themselves compelled by genuinely loving more than one person, or they are oriented toward a more open, varietal sex life than monogamy provides. So, success with any form of consensual non-monogamy, it may include necessity of getting professional help with these relationship requirements. So, folks may be coming to your office with some of these that they have in mind: personal growth, communication skills, placing more value on love and freedom than on jealousy, managing jealousy, developing, maintaining boundaries and rules, maintaining family commitment. So there are many formats in consensual non-monogamy, and this is critical when you have different people that come into your office. Polyamory for individuals, so they may be solo poly, but they know that when they want a partner, they want to have a variety of partners. Polyamory for couples, they may want to open up their relationship and have more of a committed, ongoing relationship with others. It could be a triad, or to call them throuples, where 3 people are together and they are committed to each other. They may practice something called polyfidelity, where it's the 3 of them exclusive to each other, and that does not go outside of that triad. Or there are quads, where there may be one couple that is dating another couple. Pods and polycules, meaning that people are sexually and relationship oriented together in a network of people. Polyhierarchy, where there are primary partners and there may be seconds and thirds. Remember that relationships which could be sexual or intimately related. And of course, swinging, where couples engage sexually with other couples. So there are agreements, expectations, contracts, boundaries, and rules. Consensual non-monogamy clients may use words, agreements, expectations, contracts, boundaries, and rules. It is common for individuals to believe that their expectations comprise contracts, boundaries, or rules, and that these are the same as all other partners' expectations. But you don't know that for sure. Far from a consensus existing, individuals may not even have realized or examined their own expectations, let alone openly discuss them with others. And this is where you come in to help negotiate and create those agreements if there are any. A first priority in working with consensual non-monogamy clients is to clarify the expectations of each individual and their basis. Have partners discuss specific behaviors and activities that manifest expectations of the group. Everyone needs some rules and boundaries to feel safe and to know what happens from moment to moment. When rules and boundaries are not working, these various cases may exist, and this is what I see most common that come into my practice. There are practical reasons such as time management, including schedule problems. Emotions may catalyze objections to practical arrangement, such as time allotments for each partner's shared time. A new partner may have entered the circle, which can definitely happen. Agreements may include rules or boundaries that are difficult to follow, and individuals may have mental, emotional, or temperament problems, making consensual non-monogamy negotiations and agreements difficult for them. So, how can therapists assess and intervene? Well, we can clarify agreements, rules, and boundaries that are in place. We can sort problems with agreements, rules, or boundaries versus problems with individuals' personal issues. Work with each individual to provide support and resolve personal issues. And we can help refine and fine tune agreements. Facilitate clear discussion and teach communication skills, and we can recommend repeated sessions until consistent success is experienced. And I'm going to go over this with you quickly. So, you want to get a picture of the relationship when you're clarifying agreements. How many partners are there? What is the living situation? If there are children, whose are they? Are any negotiated, articulated agreements, rules, or boundaries in place? If so, what are they? And if not, why not? You want to help define terms. As part of working with clients to develop agreements, definition of terms needs to be placed. For example, when partners try to create agreements, they may interchange rules and boundaries, and they may use important words like loyalty, trust, and honesty, among others, in different ways. Have all partners involved describe behaviors they believe express such values and how they expect others to carry them out. So you want to work with each individual partner on what do they see what's going on in terms of how they define things in the partnership. Help define the basis for rules and boundaries. When partners do have agreements, they all seem to understand how did they achieve this. There may be good negotiation and communication skills among the group, and other things may be going on. So you want to make sure you take that into account. Based upon what relationship or personal factors did partners create each agreement or rule? Who needed what? And how is the need answered by the resulting rule? You want to help sort problems with agreement, rules, and boundaries, and their personal issues. A challenge in sorting out practical from the personal is the overlap of issues and consensual non-monogamy. Problems in one area, such as time and boundaries, they may intertwine with issues such as jealousy, personal difficulties of an individual, and psychosocial events in the lives of the group. So a lot of times when we're working with couples or we're working with partners who are more involved with each other, there may be other environmental factors that come in and cause problems in the relationship. Rules can work if they can honestly be reasonably followed on how to carry them out in various situations. As in the rest of life, things happen and rules cannot always apply, but they can be used as strong guidelines. Rather than rules in some cases, boundaries, the concept of flexible guidelines, can be more realistic. Personal problems, they come into all relationships, right? When practical solutions don't correct problems, the understanding and experiences of individual partners must be considered. People bring all of themselves into relationships, whether one partner or many. Every individual has a unique blend of self, including relationship skills and problems. Overriding issues with one partner can impact agreements, how they're carried out on a daily basis. Assessment and approaches for individuals are no different in consensual non-monogamy than monogamy. Common problems may have compound effects and may need to be addressed by all partners. Help redefine and fine-tune agreements. Fine-tune agreements, rules, and boundaries to provide support and protect true needs of individuals and of each relationship. Make sure children's needs are also considered and they are the first priority. Therapists must assess how arrangements and adjustments are working. If a partner is reactionary and emotional to another when an open upon event has taken place, that partner needs to learn calm eye language and active listening rather than blowing up or arguing. You want to facilitate clear discussion and teach communication. This is what we do as therapists in our daily work. Success in consensual non-monogamy, it requires a lot of communication all the time. Awareness of feelings, speaking from the self in a relatively calm manner, listening, compassion, appreciation, confidence, and other skills are required. While communication skills are necessary to every aspect of relationships, negotiating agreements is the most demanding area in consensual non-monogamy. And you want to know what those agreements look like, and you want to send them home with homework, have them come back and talk about what they've been doing. Have them check in with each other a couple times a week on how they're defining this. The specific communication skills needed in consensual non-monogamy, they're no different those best practiced by any individual or partnership. But the number of things to discuss and plan, many emotionally charged, are multiplied. So you're not dealing with just two people in a relationship. You're dealing with many avenues and many different people. And you want to learn how to regulate that communication that goes on between each partner. You want to recommend repeated sessions. It takes time for new rules to change to take firm hold. This also applies to the creation of, changes in, or additions to rules and boundaries. Many clients stop coming to therapy when things start to get a little better, right? And we know as therapists, this is often too soon for people to stop therapy, and relapses they may occur. With more partner sex and emotions involved in consensual non-monogamy, it is important to stress the value of continued therapy check-ins, possibly with decreasing frequency of sessions. It is valuable to see individual partners alone for some sessions as well. And over time, those who cannot feel comfortable and manage this lifestyle, no matter what is tried, need help considering whether consensual non-monogamy is really correct for them. And as therapists, we hold the space to talk about that. It may not even be those individuals agree. Values may want consensual non-monogamy to work. I always tell people in my sessions, you need the big four: trust, honesty, communication, and respect. And when one of those fall, what we have to do, we have to pick up each one of those, and we have to repair that. Thank you.
Hi, everyone. My name is Dr. Stan Althoff, and I'm a clinical psychologist and sex therapist in West Palm Beach, Florida. So before I begin, we're taping this in the beginning of April. I just have a word about COVID-19 and hope that you and your loved ones are all safe, and hope that we will come out of this soon and recognize how difficult these times are for all of us and all our patients. So with that said, let me go on and start this presentation of erectile dysfunction. I am the executive director of the Center for Marital and Sexual Health of South Florida. And for many years, I was a professor at Case Western Reserve University School of Medicine in Cleveland, Ohio. So let me begin by showing you an ad that you may have seen or heard on radio or television. Before that, I do need to tell you my disclosures, and that is that I serve as a principal investigator, consultant, or member of an advisory board to all of these companies.
Here's the thing, 52% of guys experience erectile dysfunction, but 0% like talking about it. That's why we built Roman. For the first time ever, you can get ED meds prescribed online, shipped discreetly to your door. Chat online with U.S. licensed physicians.
So I just wanted to give you that introduction, which sort of replaces the ads of the early 2000s for Viagra, Cialis, and Levitra. These are our new ads for the online telemedicine groups for HIMSS, which I need to disclose that I'm an advisor of, or Roman, which was the ad that you just saw. But they are right. If you look at this, it leads us to the epidemiology. That is, that if you look at the middle line, the overall prevalence in men aged 40 to 70 was 52%. And Ed Lauman, who's in Boston, did the Massachusetts male aging study and showed the prevalence in men 40 to 70. 17% had minimal ED, 25% had moderate ED, and 10% had complete ED. So what's important to take from this is that erectile dysfunction is very much age-related. Fewer people in their 20s, 30s, and 40s have ED, but significantly more people in their 50s, 60s, and 70s have ED. So I'm going to take you on a trip through Guysville, and hopefully we'll go through this town and we'll learn about assessing erectile dysfunction, treating it, and looking at some of the associated variables. Now, again, if there are a few things I would emphasize, it's the biopsychosocial model of sexual response. You need to have, as a sex therapist, psychologist, social worker, psychiatrist, a very good understanding of this. You can't just stay in your lane of psychology or sex therapy. Especially with ED, you need to appreciate the biology, that illness, medication, surgery, all affect what's going on. Erection is a vascular and neurological event, and the person needs to be properly replete with hormones. For instance, I saw a 21-year-old just the other day, that is on teletherapy, and he told me that he was taking Androgel, which is testosterone replacement, and he also was taking a medication called Viibryd, and SNRI. Now, both of those can have an impact. It said, A, that if he had low testosterone and just started it, one of his symptoms could easily be erectile difficulties. And Viibryd, as well as other antidepressants, leads to erectile dysfunction and low desire in men. And it also leads to low desire and orgasmic problems in women. You really want to look at all these 4 areas, the psychology, especially for depression, anxiety. You want to look at the quality of the relationship and the quality of the current and past relationships. And you want to look at the stressors in the relationship. And you want to look at cultural or issues that are going on, such as privacy, couples working different shifts, and I've treated people where it's important to understand what's going on with arranged marriages. So all of these things factor into it. And you, when treating erectile dysfunction, need to appreciate all of these aspects. Now, the psychological contributions, as I said, have to do with depression, irritability, fear, shame, and embarrassment. We don't really know whether ED causes depression or depression causes ED, or there's some moderating variable in the middle. We do, however, know that there is a very strong relationship between depression and erectile dysfunction. Similarly, many men complain of anxiety, both the sexual anxiety that they develop after bouts of erectile failure, but they may have been anxious before they had the ED. And from a psychological standpoint, you need to look at developmental issues, both when the man was a youngster or adolescent. Was there trauma, sexual trauma? Was there abuse physically, emotionally? Or did he experience childhood illnesses or repeated surgeries? As an adult, was there a divorce? Did he or his partner have affairs? Was there an abandonment resulting in lack of trust that the man brings forward to the current relationship? Interpersonal issues. Was there emotional estrangement and chronic disappointment? Are there ghosts of past relationships where one fears making oneself vulnerable in the present relationship? Are there negative expectations of how this will eventuate? Does the partner have sexual problems? And I'll go more into that and give you an example in a minute. Does he or she have low desire? Is there discrepant desire, which is also an issue with couples? Is there orgasmic dysfunction? Is there sexual pain? And it's really important to look at whether there's psychiatric illness in the partner, as well as addiction and depression. And couples, when they come into you, I've seen men with ED when they're in the middle of infertility treatments, or there's really vocational stress, as many people are experiencing right now, not being able to go into work, not having money, worrying about paying rent and all their bills. Is there a lack of privacy? Is there the burden of parents or extended family, or managing a family member's chronic illness? These all actually play out in the sexual arena. As a sex therapist or psychologist, you want to try to find out what the precipitating factors are, whether they're biological, the person underwent a surgery, is taking a medication, has hormone levels that are low, or are they psychological or interpersonal? You want to know when this started and what was going on at the time this started. What's difficult is to predict what a precipitating event is. That is, for one person, it doesn't really lead to erectile dysfunction or any other symptom. And for another, it very much is the precipitating factor. We do know, however, that repetitive, problematic sexual experiences damage men's self-confidence and are a risk factor for sexual dysfunction, even in the very resilient individual. So generally, we look just at the man who's coming in, and as I say, we look at the biology, psychology, relationship, and culture. But what we don't focus on as much is that the partner can be a precipitating factor for sexual dysfunction. And I'm going to show you a videotape in a second where the partner winds up being the precipitating factor. And you can see that. You need to ask about the partner's role in terms of what they're experiencing and how that impacts the man who comes in with ED. Now, to set this up, you're going to see Carl, who's 56 years old, who was referred by his physician to a psychologist. Now, these are training tapes. Carl is actually an actor, and we worked through a script beforehand. And we also have tapes of his partner as well, and of doing conjoint therapy with them. But I just want to take you through a very typical experience. And Carl does not make it easy for me. He's somewhat reluctant to talk and has never seen a psychologist before. So bear with me as I cue this up.
Good morning, Carl.
Morning.
What brings you in?
My wife and I have been having some difficulties. It's a little difficult to talk about, but we have not been intimate for about 7 or 8 months.
I see. And what's behind you and Laura not being intimate for 7 months?
We've never had this kind of thing happen before, at least not for this long a period. I don't have the same desire. I'm having difficulty with, that kind of thing. Yeah.
You're having some erectile dysfunction.
Yeah, I guess.
You and Laura have been married for how long?
30 years.
And Carl, you're how old?
I'm 57.
Got it. And both the low desire and the ED began approximately 7 months ago.
7, 8 months ago, something like that.
What was going on in your life or Laura's life at about that time?
Without being able to pinpoint an exact date, It just seemed as though we woke up one morning and we realized we just haven't been together.
Sure. What's that been like for you?
Sometimes it's weird because I love her. I still find her to be enticing and attractive, still the same woman that I married. But at the same time, it just seems as though, okay, I'm not 25 anymore.
Sure.
I don't need to get laid every half an hour.
Yeah.
And it just seems like a normal part of life sometimes. Other times, I'm worried as to what's going on.
But it seems like a mystery to you as to why this started and why it's gone on as long.
I think the last time that we were intimate, without meaning to, I inadvertently, during the act, hurt her. She'd been having some issues down there herself, and she was in pain.
So generally, we look at the man coming in complaining of ED, and we look at the biopsychosocial factors. But we tend not to think that the partner might have been the precipitant for the dysfunction. I was going to play you a tape of my interviewing a man, but we can't seem to cue that up. So I'll have to tell it to you instead. Carl was a 56-year-old man. He's married, and he was sent to me by his physician because he's been having difficulty for 7 months with erectile dysfunction and low desire. And he's not an easy patient to interview, and clearly he's uncomfortable talking with a psychologist. And as we go on, it seems initially like a mystery to Carl why he developed the ED and low desire. And I begin to ask him what it's like for him to have the ED and what was going on in his life and his partner's life around 6-7 months ago. And he starts to tell me that there was one episode where they were making love, and he inadvertently, as he said, hurt her, and that is she started to complain of severe genital pain during intercourse. And since then, he's never been able to achieve an erection with his wife, and he didn't recognize the extent of the trauma that this produced. And so we put him, Carl, and his wife together in a conjoint treatment and had them both talk about the issues. She then was placed on medication for her genital pain, and things improved with that. And over time, we got him to regain his confidence, to know that he wouldn't hurt her, and to recognize that he was actually hurting her or making her feel badly by avoiding sexual life with her. So apologies for the tape not working. I thought it would have been a really good way to share the partner as a precipitating factor with you. So this was said in the 1970s by Masters and Johnson. They said there's no such thing as an uninvolved partner in a marriage where sexual dysfunction exists. They recognized the impact of one partner on the other. So I want to move now to assessment of erectile dysfunction. And this is relatively simple. And it will take you 3 to 4 minutes to just do this part with a patient. Essentially, I ask patients to rate their erections from 0 to 10, where 0 is no erection at all, 5 is a midpoint, and 10 would be stand up, rock hard, you could hang a towel on it. And I ask men a number of circumstances. So if you look on the screen, we have patient A and we have patient B. Patient A is essentially rating his morning erection as a 9, his erection with fantasy as an 8, by himself, the best erection he can get with masturbation is a 7, foreplay with his partner is a 6, and attempts at intercourse begin at a 5, and he loses his erection even more. If you look at patient B, there's a consistency there. He gives half an erection a 5 under all circumstances. And what should immediately jump out at you is the variability of patient A going from 9 to 5. And that is the hallmark of psychogenic erectile dysfunction. And I hope it's one of the pearls that you'll take away from this presentation. Men who by themselves, who in the middle of the night can get good erections, and who with their partner can't, really have psychogenic ED. Clearly, there are cases of mixed where the man has organic issues or biological issues, and they're made worse by his psychological response. But generally, you want to look at this kind of variable pattern as the hallmark of psychogenic erectile dysfunction. You also want to know, when did this problem begin, like with Carl? What's the duration of it? Has it gotten better or worse? And if so, what made it better or made it worse? You want to know about the couple's past and present frequency of lovemaking. It's not uncommon for couples to go from several times weekly. The ED comes up, it slips to once weekly, then once every 2 weeks, once monthly, and then hardly at all, where the man becomes avoidant of lovemaking out of fear or embarrassment and goes to sleep earlier or later than his partner. You want to know if they're accompanying sexual desire or ejaculatory concerns, because they could make matters worse. You want to know about his sexual relationship and interpersonal relationship with previous partners as well. And you want to deal with the orientation issues because they may influence how aroused the man is. In terms of medical history, we know that erectile dysfunction in usually men over 40 or 50 is associated with cardiac disease. Several studies have shown that men develop ED and 3-4 years later are diagnosed with some form of cardiac disease. So you want to look at the heart issues. You want to look at whether he presents with hypertension, diabetes, neurological issues such as spinal cord injury or cancers. You want to think about whether there are hormonal issues, whether he also says he's tired, fatigued, can't concentrate, feels depressed, has no sexual interest. If so, consider that he might have low testosterone as well or thyroid difficulties, and you'll be referring him. Again, his surgical history, men who've gone through prostate cancer and had radical prostatectomies, the vast majority of them suffer from ED. Medications, as I mentioned before, such as antidepressants, can impair desire and erection. And men hide their addiction histories. And it's important because clearly, if they're having addiction issues, they're likely to have sexual issues. And in certain cases, consider referring to a medical colleague and working up this case together. So this is another key issue here. When you focus on a sexual problem, you need to know that they exist within a person that brings with him his family history, his mental health concerns, culture, health issues, and the quality of their relationship. So really, the room is pretty crowded with a lot of things, even though it seems straightforward that he's complaining about ED. Therefore, you just don't simply use, I think I'll do sensate focus or masturbatory stop-start. You need to put yourself in the role of a psychologist, social worker, psychiatrist who will work with the whole person who has a sexual issue. So what happens to most men who have psychogenic ED? Most men will have an episode of ED sometime in their life. It may be associated, like in college, with too much alcohol, or it may be associated with fear. We're getting caught, we're in a bad place to do this, lack of attraction to a partner, religious guilt, etc. The majority of men, however, recover without incident. For a minority of men, this is truly a traumatic episode where they lose their sexual self-confidence. They become extremely ashamed, embarrassed, and fear that the ED will never go away. And then there's a shift in their focus. And here's the key for you. Rather than focusing on pleasure and sensation, these men become monitors, focus on their erection, worry about losing their erection, fear being embarrassed or letting down their partner. And obviously, there's nothing erotic in these kind of thoughts. They are distractions. And because the man is really distracted, how could he possibly maintain an erection? So this is how I address the uncomplicated issues. I tell the men, I educate them that the erection is the result of the brain focusing on exciting sensory sensations, whether they're getting stimulated, stimulating the partner, touch, smell, taste, etc. But when he's thinking about how hard he is, worrying about losing his erection, worrying about letting down his partner, there's nothing sexy in that. So why would he get hard? So I use the metaphor of two television channels, the erotic channel and the distraction channel. And the distraction channel is guaranteed to precipitate and maintain the ED. The erotic channel, especially when there are no organic issues, is guaranteed to lead to erection. What happens is once the man experiences the ED and is traumatized by it, he goes to the distraction channel and stays there, and it makes matters worse. I try to get him to be more selfish and focus on the sensations and his pleasure. And I realize that he'll go back and forth and worry. And I'll keep saying he needs to take the television remote and turn it back to the erotic channel. And he needs to do this several times. And if he does so, he will maintain his erection and gain the confidence back that he has. And you often do this in 2 or 3 sessions, and men appreciate how distracted they are and how this leads to them doing worse. More complicated cases involves resolving the trauma or the precipitating and maintaining factors. It's truly a traditional psychotherapy that's focused either on the relationship, his self-confidence, his anxiety. You can conduct it in a conjoint format if you think that's appropriate, or in an individual format. I supplement the traditional psychotherapy with, at the appropriate time, and I want to emphasize that, using sensate focus exercises or stop-start masturbation to diminish performance anxiety or restore confidence. So again, the key to this is focusing and diminishing the lack of confidence and spectatoring and the anxiety that comes from that. So 1998 changed everything for us. That was when Viagra first came out, and you saw the development of all these impotence clinics. That's what they were called then. And sort of all they tried to do is sell pills or sell injections. And they didn't concern themselves with any of the psychosocial or interpersonal issues that the men may have been experiencing. So I coined the motto for them of, we can get it up, the rest is up to you. And from moving forward, it became getting an erection is the easy part, but getting men to make love again is much more difficult. And you need to appreciate the broader context. So I created this slide for you. Now, this doesn't read crosswise or row-wise. It really reads only column-wise. And you need to think about the patient variables, partner variables, relationship variables, non-sexual variables, contextual variables, and their expectations from treatment, whether it's a medication or psychotherapy. But the point here is, if you just even start on the far right, the meaning of using a medication, that's like doing sensate focus. It has a psychological impact. For some men, it's a placebo. But for other men, it hurts them. Oh my God, I need to take a medication just to get an erection. And some men have realistic and unrealistic expectations. They fear getting addicted to these medications, which are not addicting, and so on. The interpersonal part in the middle is the longer that the couple has avoided lovemaking, the more difficult things can become. So you really need to have a partner that's interested in this. That is, if you've had abstinence of 5 years and the man thinks he comes to visit you and in 1 or 2 sessions he's just going to go home and make love again, that's not a very realistic expectation or outcome of the treatment, because he has to prepare the partner. He can't just go home one Saturday and say, take his clothes off and say, here I am, honey, it's time to make love. She'll be shocked rather than sexually turned on. So again, consider all of these issues when you're treating erectile dysfunction. So I want to go over some of the medical interventions for ED. What you know as Viagra, known as sildenafil, or Cialis, Levitra, or Stenda, are all PDE5 inhibitors. That is phosphodiesterase type 5 inhibitors. They work very well in men. They're now off patent, so they can be purchased in their generic forms from like Roman, the ad we started with, or for Hims. Of course, you need to speak to a physician and you need to get a prescription. They work well, as I said, but they're contraindicated in men who take nitrates, and they have other, shall we say, they don't mix well with other medications like HIV medications and some of the BPH medications that men may take. But they're considered the first line of treatment. They don't work well in men who've had a radical prostatectomy or men who have had diabetes. Generally then, after they don't work and people give them a try, we go to something called intracavernosal injection, where we teach men to inject themselves in the penis with a cocktail of drugs. It can be one drug like alprostadel, or it can be Trimix, which is a mixture of papaverin, regitine, and phentolamine. Or there's something called Muse, where the man inserts the stem of the device into the urethra, pushes a button, and he's given PGE1, which is alprostadel. We have vacuum pump therapy and a penile prosthesis. I'm going to show you pictures of all of these and talk a little more as we go. So this is a picture of a vacuum pump device, and it's useful for men who are not willing to take an oral medication or don't have an interest in doing so, or have a contraindication such as they're taking nitrates. And for some, it's a patient preference. Essentially, what happens here is that you put a ring, like a rubber band with wings, around the base of the penis. I'm sorry, let me start that again. Essentially, what happens is the man inserts the penis into the pump, and there's a pressure differential where the blood is forced into the penis. The man gets an erection, and a rubber band with wings, which had been placed on the outside of this, is now slipped onto the base of the penis, and that maintains the erection. That rubber band with wings needs to be removed within 30 minutes. But essentially, these work very well. They're a little difficult to get used to, but many men don't like them because they're very unerotic. Next, we have, as I mentioned, intracavernosal injection, and this works very well. For instance, this is really the treatment of choice for patients who have undergone a radical prostatectomy. Again, it's somewhat artificial, but it works well in certain conditions, and it's very reliable. That is, men learn to inject the penis, and you can get an erection within 20 minutes, and the erection usually subsides in about half an hour to 45 minutes. In the television commercials, this is the drug that causes the 4-hour erection, and truly it becomes a urological emergency if the man develops this more than 4-hour erection called a priapism. They need to go to the emergency room for treatment. This is the Muse, which is where the alprostadel, that stem is inserted into the urethra. and that button on the top is pushed, and alprostadil goes into the urethra. This doesn't really work that well. It works in about 48% of men. There often are complaints of pain from the alprostadil. So generally, the other two measures, the vacuum pump or the injections, tend to be preferred over this. If none of the above work, this is really a third line of treatment. This is an example here of a penile prosthesis. You see the two rods, and they're inserted into the left and right side of the penis. The pump that you see on the top there is inserted in the abdomen, and the pump that's on the bottom there is inserted into the scrotum. By pumping, there's a transfer of the liquid to the rods in the penis, and that creates the erection. There are several different modifications or alternatives to penile prosthesis, but generally men who undergo this procedure are satisfied. However, this is mechanical. So like your car, this may break after 5 to 10 years and needs to be repaired or replaced. Finally, I want to talk about combination or integrated therapy. That is the use of medication and the use of sex therapy. I think this has the most potential to help people. For instance, giving sildenafil or Cialis, which is tadalafil, helps kickstart a treatment in some cases. I don't always do that, but when there's a severe lack of confidence, you sort of are using these drugs as a placebo to get the man started, to restore his erection, and you then get a chance to deal with some of the other issues as well. This really harnesses the power of the mind as well as the power of biology to help the man or couple. We now have more than 25 research studies that show that combination therapy is superior to drug alone. So it's really surprising that we don't hear more or see more of this. But I think we tend to stay in our own lanes. Physicians tend to prescribe medication. Psychologists tend to do sex therapy. But really, perhaps the best treatment that we can do for some men is to combine them or integrate them. So I hope today has been useful to you to get a sense of how to think about ED in terms of the biopsychosocial approach, how to assess it, how to consider medical as well as psychological issues, how to treat the psychological or interpersonal issues, and also becoming aware of what the medical interventions might be for your patient, and consider combining them in your treatment. Thank you for listening.